Dr. Koch, he does not require any introduction. All of us who do IOL power calculation have heard about him. But anyway, for the formality's sake, Dr. Koch is a professor of ophthalmology and the Alan Mosbacher and Law Chair in Ophthalmology of the Cullen Eye Institute, Baylor College of Medicine. He has taught over 300 residents and fellows and has over 300 peer-reviewed articles and given 41 named lectures, including the Jackson Memorial, Kellman, Binkhorst, Baraker, and Lance lectures at the American Academy. And then he also has given the Charles Kellman Innovative Lecture at the ACRS, the Binkhorst Medal Lecture at the ACRS, and the Arthur Lim Lecture at the APCRS. He is the editor emeritus of JCRS and past president of the American Ophthalmological Society, ASCRS, and international member and the past president of IIIC, International Intraocular Implant Club. So with these words of introduction, over to you, Dr. Dowd. Can we have his slides on the screen?
They're
Oh, yeah.
good.
Yeah.
Thank you, Roop. What a pleasure it is to be here. You have heard several excellent talks. I could almost just sit down because everybody did such a great job covering the topics, but I'll go ahead and talk a little bit about. It's interesting to think of the history. The first IOL was 1949 when Ridley implanted it, and that patient came out minus 20. And so he had to do an IOL exchange. So that was also the first IOL exchange. The first Virgin's formula was 1967, Fyodorov. Then the first regression, 1990, with Retzlaff, Sanders, and Kraft, SRK. And then the first ray tracing formula by Rolf Preusner in 2002. Well, you've already heard this paper discussed that with Adi Abalafia. Most of us are probably hitting about 80% within a half diopter of target. The best one is this one paper that showed that you could be 92%. We use Veracity, which is a system from Zeiss that amalgamates all of our data. And I took a snapshot at one day, and I found that I was 91% within a half diopter. I took a snapshot of my data about 3 months later, and guess what? I was 85%. So I'm afraid to take another snapshot of my data. I may be at 60%. We'll see. But it's interesting to have something like this that can actually continuously evaluate your data. So where are we? I think if we're really good, in most patients, we're about 90%, which, as mentioned, I tell patients you've got a 1 in 10 chance. You're going to be off by more than you want. But is it even routinely achievable? Well, we calculate power in a number of ways. The classic formula is the Virgin's formula, where the power is is calculated using the predicted refraction, the axial length, the average K, and the ELP. And the ELP, of course, is one of the big problems because every formula has its own internal formula for calculating effective lens position using various variables. So how do we measure? What do we measure? We measure anterior corneal curvature, axial length, anterior chamber depth, lens thickness, corneal diameter, and some programs use posterior corneal curvature as well. But those top 5 are the ones that the newest formulas use routinely. Corneal thickness is another. And some formulas use some combination of these: refraction, age, gender, ethnicity, the ratio of the curvature of the posterior cornea to the anterior cornea, and corneal asphericity. So the sources of error in our world today are ELP calculation, cornea anterior, cornea posterior, and I still think we have some questions about the posterior cornea, and refraction, because we need accurate refractions to report our data. And even axial length measurement is not infallible, and I think that's why, for me, I always like to see 2 different axial length measurements in my patients to make sure that there's good consistency, because you can be off if the patient wasn't fixating correctly, for example. And we use validation criteria for axial length. If the eyes, right or left, are within 0.2 millimeters, I feel better. The standard deviation for axial length should be less than 0.02 millimeters, and the range for phakic anterior chamber depth 2.5 to 4.5, and lens thickness 4.0 to 5.5. I operated on a lady last week whose lens thickness was 5.9. I felt like I was in the operating room for 2 hours trying to get that lens out of the eye. So we have a huge number of formulas that keep being developed. And all of them primarily are designed to overcome this problem of how do you calculate the effective lens position. And I wrote an editorial in 2018 in the JCRS. I think it's time to really stop classifying formulas by generation. Instead, look at them by the type. Those that use geometric optics, and they differ primarily by the number of variables that are used for calculating the ELP, ray tracing formulas, purely artificial intelligence formulas such as the Hill RBF3, and a series of formulas that combine all of these different parameters, some geometric optics, maybe some ray tracing, some artificial intelligence. But the truth of the matter is, every one of our formulas uses some form of at least big data, looking at results, and they use those results to refine the formulas for the ELP that are calculated. And so there's a kind of a smearing or a combination. These distinctions are becoming less and less valid. Ideally, ray tracing should give us the best results because it incorporates all of the aberrations from the front of the cornea, from the back of the cornea, from the lens implant. But the limitation that ray tracing faces is the same one every one of these formulas traces. It doesn't provide a solution to calculating ELP that is unique from other formulas. So it really has not turned out to be any better than our other formulas. And it's probably going to have a more useful role in eyes with irregular corneas, but the data to date don't suggest that that's come to pass. So what do we do about predicting the ELP? Can we be more accurate? People have used OCT either preoperatively or intraoperatively to try to look at the lens equator and use that and some anatomical features of the lens capsule itself to improve the ELP prediction. And some of these studies have shown that the ELP prediction is a little bit better, but none of them in those studies have translated actually to more accurate IOL calculations. And the bad news is, with the ELP shifts postoperatively, and I think it's unpredictable. How many of you have seen a patient who's 20/20 on day one post-op and they come back at 3 weeks or 4 weeks and they're minus 75 or -1 and furious? I mean, we all see those. And and there was a paper by Nino Hernschall where he showed that 17.6% of eyes, the ACD shifted a millimeter or more from 1 hour to 2 months. Now that's discouraging. So is there anything we can do about the ELP issue? Well, I think that it will probably get a little bit better with some advanced imaging. If ultrasound, for example, could become easier and more facile, but it's still a problem. And the biggest problem with ELP is in short eyes. So short eyes, I think, are, in my practice, one of the biggest challenges because it's they typically have a shallow anterior chamber, but they get a short axial length. The cornea, these short eyes, can be flat or steep, depending on the type of short eye and what the anterior segment looks like. The anterior segment can be small or normal. The lens is usually thick. The sclera is thickened. And there's a lot of variation among eyes. So the formulas for short eyes are routinely challenged. And this is a wonderful slide from Thomas Olson, inventor of the Olson ray tracing formula, where as you can see, as you move to the left, as the shorter the axial length, the greater the error. 1 millimeter error in ELP results in errors in the accuracy of 2 diopters or more. And here's a good example. This is my patient, hyperope, axial length 21.4, shallow anterior chamber 2.39, fairly thick lens, corneal diameter quite normal. So I used that Barrett, Holiday 2, and the Hill RBF3. That's what they calculated, and the outcome was -2. So the prediction error was around 2 diopters, and the postoperative anterior chamber depth was 3.6, which is fairly shallow for a pseudophakic eye. So I exchanged it. How do you calculate the power when you're doing an IOL exchange? Well, the Barrett formula is very good. And there's also what we call the subtraction method, where you simply take the myopic error and you multiply by 1.2, very simple rule of thumb, and both the Barrett and the subtraction method said I should put in a 25.5, which I did, and she ended up plano plus a half at 175. Very happy. What do I do for the second eye? Well, the second eye had similar anatomy as the first eye. And the old teaching is that if you have an error in one eye, you should adjust the other eye by half of that amount. That's based on a series of papers, one of them Thomas Olson. So that's what I did. I targeted around +1 for the other eye, thinking that she might end up around Plano, and she ended up -1.6 spherical equivalent, and so luckily she loves her monovision. But that just goes to show, with these eyes, with this unusual anatomy, and they're very similar to each other, we should adjust the IOL power 1:1. That would have meant I would have had to aim for +2 in her other eye, which takes a lot of courage to do, but that would have given her a more accurate calculation. We did a paper recently looking at segmented axial length, artificial intelligence approaches to short eyes. We looked at the best formulas, 155 single eyes, 123 paired eyes, axial lengths ranging not that short, 19.77 to 22, 3 IOL models, and we looked at 15 formulas. We used the newest statistics, and we looked at the top ones. This is the Zeiss AI IOL calculator, which is available from Zeiss, but it's only available on their program Veracity. And what it does is it first takes 500,000 eyes and then ray tracing using real parameters. It then looks at the post-op prediction with those and compares it to those other calculations, and the formulas are constantly refined by post-operative data. And if we look at the percentage of eyes in these short eyes again, within a half diopter, the Zeiss AI was 73%, but every other one, including the Hill RBF, the Barrett, and so on, were under 70% within a half diopter. So if you got a short eye patient, you have to tell them they've got probably a 4 out of 10 or a 3 out of 10 chance of not being accurate. So let's go back to my patient. Did any of these formulas work well in my patient? And the answer is no, they were all off, including the Zeiss AI. Actually, the Koch formula was the most accurate there. In nanophthalmos is even more challenging. The formulas can have errors by 5 diopters or more, and we have a challenge because in the US, we have the highest power IOL we have is 40. You folks from India and internationally can get other special lenses. One was from Human Optics, and a company from Italy, Soleco, up to 72 diopters. But remember, these eyes can be really inaccurate. And piggyback IOLs, I actually learned this from colleagues here in India. You have access to these wonderful add-on lenses that I think this is the one time in a short eye one could probably use a piggyback IOL, but I'd like to hear people's experience with that. Long eyes were doing better. The first real breakthrough was our Wang-Koch modification, where we took the axial length and we put it through a formula, and we just looked at analysis of 1,600 eyes, and we had 93% within a half diopter. So we do very well with long eyes, and you also have access to great formulas now with the Hill RBF, the Barrett, the Kane, and the Olson. And we're doing better with them because the power of the IOL is low, and so the ELP has much less impact about outcome. Well, what about the cornea? You've heard some great talks this morning about the cornea. And the cornea is the largest source of error over which we have at least some control as surgeons, as you've heard this morning. It affects the accuracy of our calculations, which kind of IOL we should be using for our patients, and what we can predict the postoperative vision to be. Here's an example of a patient of mine. These are the readings on the preoperative visit, the K4334, astigmatism 2.05 at 174. IOL Master didn't give me any K readings for this patient. And I looked at the Myers, and there was a missing data point down there on the lower left. There's one of the Myers did not reflect. So it turns out I had measured this patient 3 months previously with a Galilei, and the K readings were 44.6 compared to the 4334 with a Lenstar, and the astigmatism was 1/10 of a diopter compared to 2 diopters with a Lenstar. And I looked at the Lenstar, and you can see there are distorted Myers in exactly the same area that I had with the IOL Master. Well, what I did, of course, is treated the dry eye, and actually within a week everything was uniform. And on post-op week 3, we had good readings, 20/20 J2 with an EDOF. So the lessons are you need more than one measurement. You've got to verify the quality of your data. And we've seen a good example of that. These Myers are very easy to see. The slides earlier that showed the Myers, that's more subtle, so you have to look very carefully. And you can use mathematics, the standard deviation that Warren Hill has taught us. If the standard deviation for the power is over 0.3 or for degrees over 3.5, you have to really be wary. In my clinic, we get placido topography and tomography on every new patient and every pre-op patient. That's the Galilei. And I like the Galilei because it has Myers, it has the placido Myers, and that gives me a good sense of the raw data. And unfortunately, with the Pentacam, you don't get those data. You don't see the image, and you don't get a good sense of the surface quality with the Pentacam. Biometry, I use 2 devices. So I have a total of at least 3 measurements in my patients. And 2 weeks prior to, you've heard this again discussed this morning, every one of my patients is instructed to use preservative-free artificial tears, warm compresses, and lid scrubs for 2 weeks prior to IOL calculations. And we actually have a little counter where they can buy them as they go out the door, so they have them in their hand and take them home. So we heard a great talk about the post-LASIK eye. The interesting thing about the post-LASIK eye, if you think about it, is I mentioned the 3 sources of error. Well, those are the things that are magnified in the post-LASIK eye. The ELP, because the formulas use corneal power to calculate ELP, and it's been, of course, corneal power has changed. The cornea, the greater variability of the anterior cornea, we have this problem that when you measure the anterior cornea, it doesn't accurately reflect the posterior cornea in the post-LASIK eye, and refraction has soft endpoints. If you look at the series of all the papers that are out there, one study showed 85% with a half diopter of target, but every other study for myopic LASIK is less than 73%. And as you've heard, hyperopic LASIK patients can be even more challenging. One study showed 73%, but our results in a paper we published was 57%. Very disappointing. We thought that once we started measuring the posterior cornea and took that source of error out of our calculations, that we would become more accurate, and it really hasn't given us that much benefit. We just published a study on 85 eyes, and you can see the formulas we used, all the newest formulas, EVO, Hover QST, Pearl DGS, Holiday 1 and 2, and of course the Barrett. And what we found is only the Barrett was actually 73% within a half diopter of target, and every other formula was less than 70%, and just matches what you heard earlier today. Some of these formulas actually were off by more than a diopter, so you really have to warn your patients about this. Post-RK is even worse. I tell these patients, these are the most inaccurate eyes. And why is that? It's because when you measure the posterior, the RK cornea, you can measure the anterior cornea, and of course there's a lot of variability, but the RK, radial keratotomy, really affects the posterior cornea in a very unpredictable way as well. And so most studies show accuracy of less than 70%. One study showed 76%, but much better than our experience. And so we still like, in these things, to look at the Barrett True K, the average of the Ascaris calculator values, and I think that some of these newer formulas such as EVO, Pearl DGS, and so on are going to be really good as they get refined. So I'm a real fan of postoperative adjustment. And this is the RX site. You've heard about it. I don't know that you have access to it yet in India. It really is precise, but boy, it's expensive and it takes a lot of time. But of course, what it does, it has polymers or macromers in there that are not polymerized, and you can then treat them with light postoperatively to make these adjustments. And you can adjust up to about 2 diopters of sphere, up to 3 diopters of cylinder, and you can do up to 3 adjustments, and then you have to do 2 lock-in treatments to remove any remaining unpolymerized macromers. We start the treatments about 4 weeks post-op in our post-LASIK eyes. In an RK eyes, we wait 8 weeks to make sure they've stabilized, and it takes a long process. It's a long process for these eyes. And if you look at our accuracy, You can see on the right, in normal eyes, we were 96% within a half diopter. In LASIK eyes, 93% within a half diopter. In RK eyes, 84% within a half diopter. So these are certainly far better than anything that we can get with our standard IOL calculations, but it's a lot of time and a lot of effort. What about keratoconus? Well, we published a paper on this, looked at a variety of IOLs, we looked and included the Kane keratoconus and the Barrett keratoconus. And if the K readings were less than 50, we were getting about 70% within a half diopter target. If they're over 50, less than 20%. So there seems to be kind of around 49, 50, a big change. And of course, those are the corneas that have a lot more irregularity in their topography. And these are the best formulas in our study. There was discussion about statistical methods. We, with Jack Holliday, published a paper that showed that when you're doing IOL calculation analysis, the data are not normally distributed. You need contemporary statistics, and the standard deviation is the primary metric for formula comparison, and you can use this statistics even if the data are normally distributed, so you don't have to worry about that. This is all the information. You can read that about that in JCRS. And we also have now access to this wonderful website from Adi Abalafia called ITEMUS, and that also incorporates the concepts of the data not being normally distributed, and it's very user-friendly, and it's a great option. So, can we do better, or is 90% within a half diopter really is truly our ceiling? One other cause of error is these are kind of crazy numbers if you look at them. If you look at the manufacturing accuracy that ISO requires, for example, if you go from 15 to 25, the tolerance is plus or minus 0.4 diopters. Now, we know the manufacturers do better than that, but they're not held to very stringent criteria, and those numbers are pretty dismaying. So in conclusion, we're doing better. But we're really approaching a ceiling for accuracy in our calculations. And I think postoperative adjustment's going to come along, either something like RxSight, or maybe this concept of refractive index shaping that is where you can actually take an IOL in the eye and adjust the power using a femtosecond laser. So it's an interesting time. We have a lot to do. And I think one other thing I'll just say is I think the future for all of us is going to be surgical planning software. And there are a number of them out there. Veracity, iTelligence is from Bausch & Lomb, the Cassini planner, and Alcon will be coming out with its planner. And here's an example of how you can use it in your practice. This is a patient of mine, wanted great distance vision, no glare, but some intermediate vision as well. So this is the left eye, the eye for intermediate, and there are the axial length data. You can see them, it just presented right to you. You can see the similarity in axial length. And you can see that the refraction, the K readings show astigmatism of around 0.3, 0.4 diopters at 30 degrees. And you kind of look at that and say, I don't really need to use a toric in this guy. He doesn't need it. And that's what the integrated K from Barrett is done. And then if we put a monofocal IOL in, the predicted refraction is, look at that, 0.68 at 10 degrees. So that would leave him against the rule, and he's 68. That's going to keep going against the rule. So let's see what it looks like if you put a toric in him. And if you put a one diopter toric lens in him, now the predicted refraction is 0.3 diopters at 100. So that's what I did. I put a toric in, and I aimed for intermediate, and he's 20/20 J2, and he has a half diopter at 75, which will gradually decline over many years as it goes against the rule. So you can see how the software really facilitates working through these issues with your patient very easily. Best practices this year: get more than one corneal measurement, preferably 2 or 3. Verify the quality of your data, and we have to educate our patients that this is an imperfect science. And of course, have a strategy to manage postoperative refractive errors, particularly with our multifocal patients. And I really thank you for the honor of giving this talk.
Thank you so much, Doc, for your beautiful presentation. So I just have a question for you. Now in India, we have 2 sweep source OCT-based optical biometric devices. One is the ARGOS, other one is IONmaster 700, which are really commonly used. ARGOS always gives the segmental, the sum of the segment axial length. Now is it okay to use that axial length in the standard formulas that we use like Barrett Universal 2 or Barrett toric? Because I think they are meant for the composite axial length, not the sum of the segments.
Right. You know, the Barrett formula and a lot of the other formulas have already kind of taken into account the segmentation in the way that they do their calculations. So with the Argos, my understanding is, we don't have an Argos, my understanding is you have to use a slightly different 8 constant in the Argos in order to account for the fact the axial lengths are segmented. I don't think probably you can use the same one in each, but I would wonder, is that your experience? Did you come up with different numbers?
No, I mean, that I don't use Argos either, so I don't have a personal experience. But what I've heard is Argos, they have evolved in Barrett formula, which actually takes into account the sum of the segment.
Yeah.
And that is supposed to be more accurate than when you use the composite axial length for the Barrett U2, universal 2 formula.
Yeah, you know, our paper on short eyes, we did the segmentation and optimized, and we didn't find that it made much difference. Because again, the formulas have, if you look at something like the Barrett formula, it's got hundreds of lines of code where all this stuff is folded in. You know, our axial length modification, all that stuff is already in the Barrett. And he's done a great job of kind of bringing whatever is available in. And so when you go to a new biometer, you know, it's going to take some time to kind of sort that out, probably. It would be my guess.
Any questions for Dr. Dow?
So wonderful
one
session.
question, yeah.
Yeah. So what would be your recommendation for calculating IOL power post press beyond LASIK? And it's a slightly hyperopic eye, or what kind of formula could be? Press beyond LASIK.
What for what kind of patient?
Post press beyond LASIK. Press beyond, the blended laser vision correction.
Press beyond, the ablation profile for press beyond. Well, that's a version of a hyperopic LASIK, right? So
Yes.
I guess you would have to use your hyperopic LASIK formulas, you know. But like sometimes I know particularly with the Zeiss laser that does press beyond, people are treating very high amounts of hyperopia, and the greater the hyperopic treatment, the more error you're going to have in your postoperative IOL calculations. So. Like everyone, I would say, first of all, thinking about the IOL, look at the corneal asphericity. After hyperopic LASIK, actually most corneas have about 0 asphericity, but for something like that, they're probably going to have negative asphericity, so you might want to use a lens that has 0 asphericity. But I would be very prepared to have to do an IOL exchange. Do your hyperopic LASIK calculation and tell the patient, you know, you've got maybe a 1 in 10 chance of needing an IOL exchange to get the most accuracy.
Which IOL would you prefer?
Well, you know, which IOL?
Primary, the first one.
Well, you know, I don't know what you have available to you here. We would use the Bausch & Lomb Invista model, which has 0 asphericity. There are other IOL companies that make IOLs with 0 asphericity. I just don't know what you have available here.
We have Invista.
Yeah. We have 3 more presentations to go. Maybe last comment from Anand.
I was just curious because when we look at, we've been using the Bausch & Lomb, the lens that you mentioned, Invista, as a option for myopic LASIK. But my query is always about when we are looking at sphericity and we are looking at spherical aberrations, the measurements are in microns. And if you're even off by about 0.4, 0.5 diopters, the spherical aberrations have little value. What is your comment on that?
Yeah, I mean, that's right. The most important thing is getting the power right. And spherical aberration only becomes, you know, spherical aberration may become relevant if there's a lot of asphericity. Well, let's put it this way. In myopic LASIK patients, of course, there's going to be positive spherical aberration. So you can use a 0 spherical aberration IOL or one with negative asphericity in order to try to improve that. And wherever that refractive error is, you would think that the sharpness of the vision might be a little bit better, but in terms of uncorrected acuity, yeah, the asphericity of the IOL is minimal effect. Very good point compared to being off in power.
Thanks a lot, Rao, for your wonderful presentation and for the